When you walk into a doctor's office, you expect to find a sanctuary, a place built entirely around the goal of diagnosing your pain and helping you heal. But for millions of patients, that sanctuary has disappeared. If you live with chronic pain or a complex, invisible illness, the clinic has transformed into a site of active surveillance. A patient walking through these doors is met with administrative barriers and deep institutional skepticism. This shift was accelerated by the opioid epidemic. As the crisis grew, a wave of intense medical paranoia changed the way doctors interact with the people they are supposed to help. Healthcare shifted from treating physical distress to managing legal liability. This automated process uses insurance algorithms to scan your history for risk factors, like seeing multiple specialists. These flags trigger liability warnings before a human doctor ever reviews your medical context. Modern medicine now operates as a risk management bureaucracy. This leaves the most vulnerable patients stranded in the gap between their medical necessity and the institution's fear of a lawsuit. In 1971, the Stanford prison experiment showed that when people are assigned the role of guard and given total authority, they often use that power to maintain order through abuse. This sociological framework maps directly onto the modern medical system. Doctors are under intense pressure from liability rules and algorithmic oversight, pushing them into the role of the institutional guard. In this environment, the medical system prioritizes corporate safety over physical pain. Providers view a patient's request for relief as a potential threat to their medical license, rather than a symptom to be investigated. When an institution values order and liability over human life, the environment breeds systemic neglect. The goal is no longer to solve the problem, but to protect the person in charge. The first phase of the prison experiment was de-individuation. Guards stripped prisoners of their names and histories, replacing their unique identities with administrative labels. This same erasure happens in medical records. A patient's complex physical history is often replaced by stigmatizing psychological labels like malingering or psychosomatic. This creates a specific problem for the high-intelligent patient. If you know your medication's half-life, your specific dosage history, and your pharmacological needs, you are acting as a competent self-advocate. But the system weaponizes that knowledge. Instead of seeing a smart patient, providers see a drug seeker. Your expertise is used as evidence that you are trying to manipulate the system. This creates a paper trap. These subjective, stigmatizing labels are entered into the electronic health record, where they permanently alter how future providers view your case. Because clinics share records, every new doctor reads this poisoned file before they meet you. They immediately default to a circle the wagons mentality, refusing to intervene or prescribe anything that might create a liability for themselves. The medical file now serves as a liability shield. It maps out a reality designed to justify the denial of care, ensuring the original administrative narrative remains unchallenged. This dynamic enables institutional gaslighting. This occurs when a medical team uses its authority to outright deny the objective physical reality of a patient's suffering. In one instance, a patient was forced to walk on a broken toe for an entire month because the clinic insisted their pain was just an anxious or somatic complaint. To justify this neglect, the system weaponizes psychiatric concepts like distress tolerance. Doctors use these concepts to ignore life-threatening emergencies. They frame severe physical agony as a behavioral issue, responding with gray rocking, the intentional withholding of empathy, under the guise of therapy. Providers have rebranded medical neglect as a skill-building exercise for the patient. This forces the victim to bear the entire burden of surviving the doctor's refusal to treat them. Chronic pain patients are trapped in an impossible catch-22 when trying to save their own lives. If the patient displays physical agony or begs for help, they are documented as combative or emotionally dysregulated. But if the patient stops asking for help or withdraws from the abuse, the clinic charts that the medical emergency has resolved itself. Either way, the patient's needs are erased. The system is structurally rigged to disqualify the patient from treatment. There is no behavioral choice that can overcome a pre-existing administrative label. The Stanford prison experiment proves that you cannot fix a corrupted power dynamic by asking the authority figures to be more empathetic. Liability culture provides financial and professional incentives for this dehumanization. As long as doing nothing is less risky than providing care, the medical system is incapable of policing itself. True accountability requires moving beyond internal hospital policies and establishing external legal standards. Protecting the right to medical care means ensuring a patient's physical truth can never be overwritten by the convenience of the institution.